Dr. Oliver Panzer also was a speaker in that said convention. Doctors, let us all welcome Dr. Oliver Panzer, who will talk on the ultrasound findings of COVID-19 patients. Oliver?
Yes, thank you very much for that very kind introduction. I know, in these times, we all just do what we do best. We take care of patients. And I'm very happy and I'm honored to be able to contribute to this great webinar. So I'm gonna share my screen. I hope that's gonna work. Desktop 1. And please let me know if you see my slides. Do you see my slides?
Yes, I can see.
Okay. So my task, I was asked to present to you some specific lung ultrasound findings related to the COVID patients that we treated, and I prepared basically 2 classic patients that we've encountered in a similar way quite frequently, and I hope that it's going to give you a little more insight of what's happening or how to use lung ultrasound, or maybe even a point-of-care ultrasound a little more broadly. So I'm going to start with the first case, and this is going to be something you're probably going to be relatively familiar to as well. This was a gentleman in his 70s with hypertension, colon cancer, and a resection in the past. His most recent history, he came to us and he was in the OR ICU. We turned our ORs into ICU rooms because we were in dire need of intensive care beds. And we used anesthesia machines to a large extent in these first days to overcome a shortage in ventilators. And this patient unfortunately developed severe COVID ARDS. He was intubated, he was being prone and paralyzed, and was now supine for about a little less than 4 hours because he started improving. He did have a pneumothorax and a pneumomediastinum in the past, however, that's been improving. There was a suspicion of PE in the past, and he was empirically started on anticoagulation. It was never really, the CTA was never done because of his dire situation, and he was septic with an infection, but he was improving on all lines. And then by the time we encountered him, he suddenly had an increase in vasopressor support needs, so his pressors were significantly increased. At the same time, his airway pressures also increased. His peak and plateau pressures were in the mid to high 40s, and earlier they've been in the mid to high 30s, which already is high, but it was even higher. And unfortunately, we started noting some bleeding from the ET tube, from inside the ET tube, and some melena from the rectum. So just a little more information on him. He had signs of decreasing hemoglobin, so he was becoming anemic. He was therapeutic on heparin. His D-dimer, that in many of these patients, as you probably encountered, they unfortunately have a tendency to be very hypercoagulable. But his D-dimers and fibrinogens actually were reduced or normal. However, his lactate was increasing, and his oxygenation, as you can see here, was quite marginal. He was hypercarbic and hypoxic. On exam, though, he had warm extremities, he had a faint pulse, and he had okay capillary filling. This is his chest X-ray, and this is unfortunately a chest X-ray we've seen quite a bit, but his seemed more dense at that time. You can see here on the. Can everybody see my index, my cursor that's moving on the screen? Can you see that?
Yes.
Okay, good. So you can see here that there's a lot of opacification in both lungs, barely any kind of clearer areas, and we were worried about this increasing homogeneity here with the bleeding. And we also did an abdominal ultrasound at the same time, and here the report came back that this is a so-called gasless abdomen, which one of the worries is that there's ischemia. Again, in the setting of hypercoagulability, even with anticoagulation, that was a worry of ours. So when we started using the ultrasound, we basically had 5 big questions. We were worried, is this driven by what's going on in the lungs? Is this worsening ARDS? Maybe a large pleural effusion is causing these higher difficulties to ventilate. Even with intrapulmonary hemorrhage was a worry of ours, or a worsening, a reopening of the pneumothorax, or was the hemodynamic consequence more a hemorrhagic shock with the signs of bleeding and the melena, or a recurrence of sepsis or worsening RV failure and a PE. So you can see that, especially if you have these patients that are already been around for a longer time, since the complexity of COVID is so broad in terms of the organ system that it can affect, it becomes very difficult at a certain time point to really pinpoint exactly to what might affect the worsening or what the reason is of the worsening hypoxia and many times associated shock. So lung ultrasound and ultrasound in general really comes in very handy. And for the first slides, I'm just going to go in a little more detail how I did my lung ultrasound exams. And for the second patient, I'm going to be a lot briefer about this. So typically the way I start is as Penn alluded beforehand, there are different models. I do a screening exam first, where I basically have a 4-point exam where I start laterally with the diaphragm or the PLAPS, and then I move forward, move up to the lateral above the diaphragm and go anterior. So I have a total of 4 points I examine per half chest. So what you see here is the right diaphragm right here. You can see this bright line. You have the liver underneath. You have the kidney. This is the Morrison pouch. So you can see here, there's no free fluid. There doesn't seem to be a lot of effusion. You can see here a little bit of black fluid right there. But other than that, you see a lot of lung rockets. So this is probably lung with some pulmonary edema or increased lung density from the ARDS. I moved up laterally a little bit. I'm sorry about that. And you can see that there's tons of B-lines, like you've seen earlier already, but you can see here that within one window, here's a rib right there. This is the pleural line. And you can see that tons of B-lines coming off, even some of them so-called confluent. So they're really bundled together. You can't differentiate them as one, which is a classic sign for what we've seen in COVID ARDS a lot of times. And these typically, if you look at the CT scans, these bundled B-lines correlate to ground glass opacities in the CT scanner. So just to show you what's happening at the pleural line, here I've added a lung exam with a phased array probe. So you see the cone-shaped picture. I like to use phased array probe most of the time, especially if I'm dealing with ARDS and assessment of pleural effusions, because it allows me to go deeper and I still see the pleural line well. And you can see here, if you look at the pleural line, which is the first line on the right picture, it's different. This line in ARDS, in an infectious disease, it's basically thickened. You see how irregular, it's a little fuzzy, whereas here it's nice and sharp and a thin line. So that's a classic sign of ARDS, especially if it's related to an infectious disease. Here I move to the anterior segment. You see similar findings, and you can appreciate the irregular pleura right here. And this is more in the midsection. And here I want to highlight that there are some, going back again, you can see that not only is the pleura thick, but you can see these little indentations, these black areas right here with even some deeper reaching white matter and then sending off lung rockets or B-lines. And these are, most of the time, these are peripheral infiltrates, small infiltrates by either infectious agents. Sometimes if they're a little bigger, 1 to 3 centimeters, a PE can present like this, like a wedge-shaped structure at the pleural line. We're going to talk about that a little bit later. And here again, the topmost, and again, not only is the pleura thickened, but you can see these fragmentations, we call it, these interruptions of the pleura, indicative of an inflammatory or infectious disease process. Now I'm switching to the left side, and you can see here, it's a little harder to visualize because on the right side, I have the big liver that offers a great acoustic window to the deeper structures like the diaphragm. Whereas on this side, I only have the small spleen, which is more difficult to visualize, but it's, suffice it to say, I still see it right here. There's movement on the diaphragm. I don't see the spine sign, unfortunately. And you can see here, this all looks pretty dark. And you, in the beginning, you might be, mistaken by calling this or thinking about this as fluid, but as Penn highlighted before, you can only call this fluid if you clearly see the spine sign underneath. Otherwise, this is probably just an artifact and you can't really tell. You see here like the bottom of the lung sliding into the recess. Now, again, further up on the left side, again, a markedly thickened pleural line with irregularities, tons of B-lines coming up, suggesting ground glass opacities. Here again, same finding with some interruptions here. Some, you can see here like a little bit of a small layer of fluid that's classic to surround peripheral infiltrates in severe pneumonia or ARDS. And that's at the very top. And again, you see here, these are tons of confluent B-lines, so ground glass opacities overall. So, overall, this confirms a picture of like a severe ARDS or severely increased lung density that could go along with ARDS. I want to quickly highlight a study that's been done by Dr. Papetti that Penn mentioned earlier already. He did a lot of work in that regard. And he early on already developed signs in a study where he tried to differentiate just by lung ultrasound classic features of a high-pressure pulmonary edema, like a cardiogenic pulmonary edema, versus a pulmonary edema or increased lung density that would be more associated with ARDS. And you can see here the white columns representing the patients who have ARDS versus those who have classic CHF, like heart failure, in the black columns. And you can see while all of them had the B-lines and pulmonary edema called here alveolar interstitial syndrome, AIS, only the ARDS patient had lung sliding that was reduced or absent. And you saw that earlier, that the lung sliding that you've see in normal patients is not as ubiquitous, not as large. The amplitude is not as large as it is. Spared areas, which unfortunately with patients, COVID patients, are rarely seen. These are areas that look normal, meaning they have A-lines in the middle of having tons of B-lines around them. Consolidations, many of the ARDS patients, but none of the heart failure patients had them. And consolidations we do see, but mostly the peripheral ones, not the classic big ones. And the lung pulse also was more present in ARDS. So you see here, there are like several lung ultrasound findings that already can point you towards the etiology of the increased lung density or pulmonary edema. And other than the distribution, typically ARDS is inhomogeneous spread, where CHF doesn't spare any areas. This is a classic spared area with ARDS. You can see here, you see the thin pleural line, you see the A lines right here, and then you have these confluent B lines next to it. Unfortunately, COVID ARDS, we didn't see much of those. The lung disease is just too severe, whereas in CHF, you typically have no sparing. You have the lung sliding present, but you have the changes of the pleural line in ARDS are more common. You see that what I showed you earlier, really the broad, like a fluffy pleural line compared to a sharp pleural line with a non-inflammatory process like CHF and pulmonary edema. Lung sliding is many times is absent or reduced in ARDS. The lung pulse many times is present in ARDS because it's a precursor of a complete atelectasis and collapse, which is rare in CHF. And the consolidations also more likely in ARDS.